What's up, Ninja Nerds? In this video today, we're going to be talking about Staphylococcus bacteria. Before we get started, if you guys really want to understand this topic, down in the description box below, we'll have a link to our website. On there, we'll have comprehensive notes. We'll have illustrations. We have pictures before the board, after the board, everything to enable you to completely understand this topic and succeed. Please go check that out. Also, if you guys like this video, you benefit from it, please hit that like button, comment down in the comment section, and most importantly, subscribe. All right, let's get into it. All right, Ninja Nerds, so let's talk about Staphylococcus. So Staphylococcus, first off, we should actually have an understanding of what staph means and what the cocci means. Okay, so they're kind of like a little bacterial nomenclature. So staph means that it's kind of in a cluster. That's one word for it. So staph basically means kind of a cluster of something, right? Whereas the cocci means round, means spherical, means berry-like. We're just going to put kind of like spherical. We'll put spherical. So it's a cluster of spheres, but here's what's really interesting about Staphylococcus. All of the Staphylococcus species are gram-positive. Go back to what color gram-positive bacteria stain when you do the gram stain. Do they retain the crystal violet or not? They retain the crystal violet because remember, they have that very thick peptidoglycan layer. If they actually retain the crystal violet, what color does that give? Crystal violet or a purple-like appearance. What does a cluster of purple spheres look like? A bunch of grapes. So sometimes we'll use the term that Staphylococcus looks like a cluster of grapes. So Staphylococcus is a cluster of spheres that are gram-positive, meaning they look like a cluster of grapes. They're also non-motile, meaning that they don't have any flagella that enable them to be able to move around in different areas. And they're also, here's where it's really, really important, they're all catalase positive. And I am going to explain what this means in just a second. Before we do that though, what I want us to next understand is we have Staphylococcus. It's a bacteria that is in a cluster of spheres. They're gram-positive, meaning that they stain crystal violet or purple on gram staining, so they look like a cluster of grapes. They're non-motile. If you also want to remember another fact, they're what's called facultative anaerobes, which means that they can survive in oxygen environments, but they can also survive in no oxygen types of environments as well. And they're catalase positive, all the three types that we'll discuss. The next thing that I want us to discuss is where would we generally find these staphylococcal species? Like where would they actually be found within the human body? Because that's what we want to talk about. It's like medical microbiology. How is this pertinent to any kind of infections or diseases? So Staphylococcus, there's actually three particular types that I want you guys to remember. The first one is Staphylococcus aureus. So we'll put Staphylococcus Aureus. And this is a heavy kind of like colonizer of the skin. So it's very, very commonly found within the skin. It's a part of our natural skin flora. You can find it in the armpits. You can find it in the actual ears. You can find it in the pharynx. You can find it in the groin. You can find it in the perineum, a bunch of different areas. One of the most important areas that you need to remember for Staphylococcus aureus, and it will probably show up on your exam, is that it is a very, very important colonizer of the nares. So about 15% of the healthy population has colonization of Staphylococcus aureus within the skin of their nares. Okay? The other type of Staphylococcus species that's also a part of our skin flora is called Staphylococcus epidermidis. That's actually a pretty easy one to remember, right? So Staphylococcus epidermidis is another one, and this is a part of our natural skin flora, actually more so than Staphylococcus aureus, okay? That's the big one there, so those are two there. The other one is a very interesting one, and this one is called Staphylococcus saprophyticus. You're like, what the heck? So Staphylococcus saprophyticus is the other one that I want us to talk about. So Saprophyticus, you can obviously make a sense of the epidermidis. Aureus, we'll talk about where that terminology comes in just a second. But Saprophyticus actually kind of means that it's a staphylococcus that actually thrives in decaying organic material, especially like meats. So Staphylococcus saprophyticus can actually thrive and survive in decaying types of organic material like meat. So imagine you take and you eat a piece of steak. You eat some steak. That steak has potential decaying type of organic material. The Staphylococcus saprophyticus survives on that. You eat that meat. When you eat the meat and then you decide to go ahead and digest it and so on and so forth, you poop out some of the actual contents of that actual substance. Within the actual fecal matter that's actually coming out of the GI tract near the actual rectum area, you're going to have some Staphylococcus saprophyticus. So it loves to colonize around an area called the perineum. So it's the, you know, the perineum. So the perineum is the space between the anus and the genitals, right? So you can always remember, I'd rather get kicked in the peroneal region than get kicked in the perineum, right? So it's the space between the anus and the genitals. So that Saprophyticus species will actually kind of colonize within that perineum area. Now, in females, their urogenital tract is very, very in close proximity to the anus and to the perineal area. So what happens is the actual bacteria can quick and easily spread to their actual urogenital tract and colonize those areas as well. So not only will you find this in the perineum, but you may also find this within the urogenital tract, okay? But particularly more emphasis on the urinary tract. All right, so it's a big, big thing I want you to remember. Staphylococcus saprophyticus survives on decaying organic material. Usually it's within the GI flora because you're eating foods that it's contained on. You poop it out, it actually stays within the perineum, and because the female urethra is very, very close proximity and short, it can easily kind of colonize into the actual female urethra, a part of the urogenital tract. All right, beautiful. We have the 3 particular staphylococcal species that I want you guys to remember, where you'll find them, kind of where they colonize, what category of bacteria they are, non-motile, facultative anaerobes, and going back to this concept of their catalase positive. What the heck does that even mean? Don't worry, I got you. Catalase positive means that these bacteria, Staphylococcus aureus, Staphylococcus epidermidis, and Staphylococcus saprophyticus all contain an enzyme called catalase. Catalase is an enzyme that if you take hydrogen peroxide and you put that into like a petri dish with all of these 3 bacteria, the actual solution, that when you put it in there, will bubble. Why? Because they contain this catalase enzyme that converts hydrogen peroxide into water and oxygen, and the oxygen is what allows for the kind of the bubbling effect. So one of the ways that you can identify Staphylococcus, these species, is the process by which if you do a test on them, where you put them in like a petri dish and you apply hydrogen peroxide, if the solution bubbles, it's catalase positive, and all of these are catalase positive. So it's not a way to differentiate them though, right? So from this, I can say that if it's catalase positive, I know it could be Staphylococcus aureus, it could be Staphylococcus epidermidis, or it could be Staphylococcus saprophyticus. Okay, now we know that it's one of these 3 based upon it being catalase positive, being gram positive, being non-motile, facultative anaerobes. How do we kind of differentiate now between these 3 bacteria? We use another test. That's called a coagulase test. So coagulase is a very interesting enzyme. So coagulase. What coagulase is it's kind of like a prothrombin type of molecule. And so basically, coagulase will help in a process of basically kind of converting a particular molecule called fibrinogen into fibrin. Okay, so coagulase will stimulate this process. The whole significance of this is if you take a petri dish, okay, you put these bacteria in them and you apply some actual solution that you apply some kind of like colloid kind of like solution. When you apply that solution, if they have coagulase, these bacteria, they'll utilize the fibrinogen within that colloid and kind of convert it into fibrin, making everything kind of like clump up. So this kind of will produce kind of like a clumping of the actual colloid solution. Well, guess of which ones actually clump? The Staphylococcus aureus is the only one of these that clumps up. So therefore, we can say that this one is coagulase positive. But all the other ones, if you apply the colloid solution to this, in this bacteria, they do not actually produce clumping. Therefore, they do not contain the coagulase enzyme. So this one is called, these are called coagulase negative type of Staphylococcus. So far we know Staphylococcus species are catalase positive. Only Staphylococcus aureus is coagulase positive, meaning that it can convert fibrinogen into fibrin. So if you put all of these 3 bacteria into a solution of colloid, only this one will lead to fibrin formation and clumping of that solution. Beautiful. The next thing that we can also do to continue to keep differentiating these Staphylococci is you can take Staphylococcus aureus and put it into something called a mannitol salt agar. You're like, what the heck? So you can put it in this thing called a mannitol salt agar. When you actually put the Staphylococcus aureus on the mannitol salt agar, it turns a very, very special type of color. It's kind of a golden yellow type of colonies that you form here. And that is where the aureus term comes from, is golden yellow type of bacteria. So it's a cluster of golden yellow type of bacteria is where you get the Staphylococcus aureus. So one of the big things to remember for Staphylococcus aureus, catalase positive, coagulase positive, and will actually ferment on mannitol salt agars and produce golden yellow colonies. Very important. For Staphylococcus epidermidis, you then have to differentiate this one from Staphylococcus saprophyticus. How do you do that? Because there's another similar point between them. They're both catalase positive, they're both coagulase negative, and guess what else they're both similar in? If you were to take these bacteria, put them into a solution of what's called a urea broth. It's like, what the heck is that? If you put them into something called a urea broth agar, which contains what's called a phenol red, which is kind of like a color indicator basically. A phenol red. You put both of these bacteria into this, they're going to be able to turn the color of that actual solution into a very beautiful pink color. And you're like, what the heck? How does it do that? Well, it contains a very, very special enzyme. Both of them contain a very, very special enzyme. So they contain an enzyme called urease. So both of them contain an enzyme called urease. So they're what's called urease positive. Okay? Meaning that if you put these bacteria into the solution of urea broth, they'll use that urea and convert the urea into ammonia. Ammonia is a base. And when it kind of works with the phenol red, which is kind of like the color indicator, it changes that actual kind of indicator into more of a pinkish, beautiful color. And so both Staphylococcus epidermidis and Saprophyticus are catalase positive, coagulase negative, urease positive. How are they actually different then? Here's the next test. You take an antibiotic. So you take these bacteria and you put them on something called novobiocin. It's basically an antibiotic, right? So I'm going to put both of them on novobiocin. I'm going to take both of these bacteria, put them on a petri dish, and I'm going to put this antibiotic, I'm going to kind of like slap an antibiotic right here in the center of that petri dish where all the bacteria is. The one that actually causes colonies to die off, so let's say that this one starts to die off. So some of the bacteria die off around the novobiocin because it's able to kill some of those bacteria. This means that they're novobiocin sensitive. That means they're sensitive to it and it can actually kill them. So those that are actually novobiocin sensitive is what? Staphylococcus epidermidis. If you did it on this one, which is the Staphylococcus saprophyticus, guess what? Do you think there's going to be any change, any dying off of the colonies? No. So they're resistant to the novobiocin. So they'll still be able to survive even despite the novobiocin being within that solution there. So these are called novobiocin resistant. So to quickly summarize some of the tests that you need to be able to remember for your exams. Staphylococcus species gram-positive, non-motile, facultative anaerobes. They're all catalase positive. Staph aureus is the only one that's coagulase positive and can grow golden yellow colonies on the mannitol salt agar. Staphylococcus epidermidis and Saprophyticus are coagulase negative and urease positive, but they differ in their sensitivity or resistance to novobiacin, where the Staphylococcus epidermidis is novobiacin sensitive and the Staphylococcus saprophyticus is novobiacin resistant. Now that we understand this, let's actually start talking about the pathology and how these actual bacteria cause disease. All right, engineers, let's talk about Staphylococcus aureus. So we're going to go through now kind of like the pathophysiology to explain how do these actual bacteria that now we've kind of differentiated, how do they actually cause infections, and then what kind of diseases can you actually see as a result from this pathogenic mechanisms. Let's talk about Staphylococcus aureus. So Staphylococcus aureus has a couple different ways that it can cause a lot of nasty damage. There's two particular ways. One is by a biofilm, and we'll talk about that one first. And the second one is they release something called exotoxins, okay? And we'll talk about all the particular types of exotoxins that the Staphylococcus aureus can release and all the damage that it can actually do, okay? So first thing is it causes biofilms. What the heck is a biofilm and why is that even significant? So the first thing that these actual Staphylococcus aureus bacteria can do is they can lead to these things called biofilms. Another kind of term that we use is they make what's called an exopolysaccharide layer, or an EPS. So let's say you guys take, for example, you're going to be doing like a venipuncture of some kind. Okay, you're going to be trying to puncture or put in an IV. Okay, when you puncture or put in an IV of some kind, you're trying to go into a vein, you have to go through the skin. Well, guess what's a part of our skin flora? Staphylococcus aureus. If you puncture and some of the bacteria get onto the needle, and then into the needle, they actually go into the vein, they now can kind of get introduced into the bloodstream, and they're kind of like on that actual, that venous catheter right there. What they'll start doing is, they'll start to secrete a kind of polysaccharide layer, a loose polysaccharide layer around them. So imagine all of this loose polysaccharide layer around these bacteria. You know what's interesting about this? It allows for the bacteria to be able to crosstalk with one another, pass on genetic material, pass on cell signaling mechanisms, and they have this really thick kind of polysaccharide covering. Why is that important? Because you know why that's significant? Immune system cells may not be able to break through that actual exopolysaccharide layer. Antibiotics, which you want to be able to kill the bacteria, may not be able to penetrate through that exopolysaccharide layer. And so because of that, that can make it difficult for infections to be able to be treated by antibiotics. And it can make it difficult for the immune system to actually break down the bacteria because they have this exopolysaccharide that's preventing them from being able to get to the bacteria. And so you can see this with intravenous catheters or certain types of catheter-associated infections. Okay? So you want to remember that sometimes these biofilms can lead to what's called catheter-associated infections. All right, beautiful. That's one thing. The second thing is all of these exotoxins. And there's so many of these exotoxins. Let's talk about the first type of exotoxin. The first type of exotoxin that I want you guys to remember here is what's called the toxic shock syndrome type 1. So the first one here is called toxic shock syndrome toxin type 1. When Staphylococcus aureus gets into the actual body, right? What it does is it can release this nasty, nasty toxin. And this toxin will bind on and act as what's called a super antigen. So you know antigen presenting cells, they have these things called MHC2 complexes, and they love to interact with other kinds of cells here, like your T cells. So you can also have T cells which want to interact with these MHC2 complexes via their CD4 and TCRs and all of that stuff. What happens is the toxic shock syndrome toxin type 1 will actually kind of lead to a bridging interaction between the T cell and the antigen presenting cell and stimulate and hyperstimulate their actual immune response, leading to a massive release of cytokines like interleukin 1, interleukin 2, TNF alpha, and even like interferon gamma. All of these molecules cause a massive inflammatory reaction and lead to three particular things that you need to remember. One is they can act on the skin Woo, son of a gun. Sorry guys, I literally just lost my dang marker. So again, what happens is these cytokines, they act on the skin, right? And what they can do is they can cause a really nasty rash. Okay, so they can cause some rash and basically some inflammation of the skin. Second thing they can do is they can also increase capillary permeability, cause vasodilation of the blood vessels, which can lead to hypotension, so low blood pressure. And they can also act on the hypothalamus, increasing the prostaglandin E2 release, increasing your body's internal temperature, leading to fever. And these three things combined, rash, hypotension, and fever, lead to something called toxic shock syndrome. This is something that you can see with Staphylococcus aureus. Whenever the bacteria are thriving on particular types of things that have stayed within the body for a little bit too long. The classic example is like tampons that were left in for too long, never actually taken out, and the bacteria can actually survive on that and release that toxic shock syndrome toxin type 1, leading to rash, hypotension, and fever. Or nasal packing that stays in for a long time without any kind of like antibiotic impregnation on it of some kind. Or maybe you had a surgery and they left like a lap pad in there, and that foreign material also contained the Staphylococcus aureus, and it started releasing some of that toxins. So those are examples that you guys need to remember. So this is the first type. The second toxin that I want you guys to remember is what's called a leukocidin. It's called a leukocidin toxin. It's actually called palin-valentine leukocidin protein, or exotoxin. And what this actually does is, this guy actually comes and creates pores inside of particular types of leukocytes. So it creates little pores or membranes within inside leukocytes that leads to particular types of ions or different things to float in and out of these actual white blood cells, leading to these white blood cells undergoing necrosis. And then what happens is when these white blood cells actually undergo necrosis and die, it leads to a massive amount of inflammation. And this is very common in a particular area of the body, like in the lungs. So whenever this inflammation occurs, it starts causing damage to some of the actual parenchymal lung tissue. And some of these actual tissue cells in the lung actually undergo necrosis as well. And this can lead to what's called a necrotizing pneumonia that you can sometimes see with Staphylococcus aureus due to the leukocidin exotoxin. Okay, what else? So we got toxic shock syndrome toxin type 1, we got leukocidin, we even covered the biofilms. The third thing that we got to talk about, there's another type of exotoxin, and this is called an exfoliative toxin. So this is called the exfoliative toxin. You might even get the name by this, exfoliation. So it probably has something to do with the skin. Yes, it does. There's a really, really nasty disease that you can see from this, and we'll talk about it in a second, called staphylococcal scalded skin syndrome, or Ritter's disease. What happens is this toxin loves to lead to, it targets a very particular protein. You know these skin cells here? You know within our skin we have very particular skin cells. We actually have, what are they called? They're called keratinocytes, right? So these are called keratinocytes. In between the keratinocytes, there's particular cell adhesion molecules that link them together really, really tightly. And the protein that's incorporated into that is called desmoglin type 1. Exfoliative toxins love to lead to the damage or the destruction of desmoglin 1 between these keratinocytes. If you start to damage this, the connection between these keratinocytes is lost. So they're no longer able to kind of stay stuck together really well. If your skin cells aren't able to stay stuck together very well, what will start happening? It'll start forming blisters. And eventually those blisters will actually slough off and you'll start losing skin from there. And that can lead to this condition called staphylococcal scalded skin syndrome that you can see in kids, usually like less than 6 years of age. Okay, so we got biofilm, we got our toxic shock syndrome toxin type 1, our leukocidin, and our exfoliative toxin. There's another type of exotoxin that's released from this bacteria and some of the negative effects of it. It also releases a nasty type of hemolysin. So it can release something called a hemolysin and via an enzyme called beta hemolysin. So it's actually called beta hemolysin. This is another type of exotoxin that can actually lead to the destruction of the red blood cell membrane. You know, it destroys the red blood cell membrane. And when it destroys the red blood cell membrane, it leads to the hemoglobin being released out from here. And then the hemoglobin will also get destroyed. So one of the big things that you can see from this is this can lead to what's called red blood cell destruction. This is a very important concept, okay? Because Staphylococcus aureus, another thing that you can do is, when you actually do testing of this, you can take like a petri dish, let's say for example. Let's say here we have like a plate here, a blood auger, okay? You take a blood auger, so you basically take and you have blood cells on this actual plate. And then you put some of the Staphylococcus species on this actual plate. When you do that, the Staphylococcus aureus will release beta hemolysins. And when it releases the beta hemolysins, it'll cause destruction of red blood cells on the actual blood auger plate. So what will you get? You'll get little empty spots where no blood is. Why? Because the Staphylococcus aureus was causing destruction of those red blood cells, which again, you can get through this test here. Okay, so whenever you put Staphylococcus aureus on a blood auger plate and you see empty spots, it's because of that exotoxin. Okay? The last thing for this one, as if there wasn't enough, is it also releases one last exotoxin, and this is called enterotoxin. And you can already probably guess what this one does. The enterotoxin is an exotoxin that actually targets some of the enterocytes within the epithelial lining of the GI tract. It targets them. It produces different types of pores and dysfunctional proteins within inside of it. Actually leads to the destruction of the actual cell membrane, okay, within these actual enterocytes. And then what happens is some of the sodium and water, which is inside of those actual cells, leak out. And the intestinal cells aren't able to do their function, which is absorb nutrients, absorb water, absorb electrolytes. So you start losing that function of being able to absorb particular types of chemicals. And so as a result, if there is a decreased absorption, and there's a lot of electrolyte, like we'll put positive, negative, because there's different types of electrolytes that are shifting around back and forth between the actual GI tract. So there's decreased absorption, a lot of electrolyte shifts. Guess what's going to happen? You're going to start peeing out your butt, okay? And this is going to lead to a lot of diarrhea. And it's also going to lead to a lot of inflammation because it's damaging the actual epithelial lining of the GI tract, which is going to lead to a gastroenteritis. So one of the effects out of this is you can see something called gastroenteritis. And usually this happens within like anywhere like less than 6 hours after eating some type of food that, like, usually the example that they use in the exams is some type of like mayonnaise containing type of food. It's very rich within Staphylococcus aureus potentially that allows for it to be able to produce this negative gastroenteritic-like effect. All right, so that covers our Staphylococcus aureus and how it causes these pathogenic mechanisms. We'll explain in a little bit how all of these pathogenic mechanisms produce very specific diseases. Okay, let's now, before we do that, cover how the pathogenic mechanisms of Epidermidis and Saprophyticus of Staphylococci species also have pathogenic mechanisms. All right, so Staphylococcus epidermidis, this is a really cool guy as well. So again, we know that this is a part of our natural skin flora. And so the main mechanism by which this bacteria produces particular types of diseases is by it forming those things called biofilms. And we already kind of understand how it does that. Remember, it excretes that nice little like exopolysaccharide kind of covering around it that allows for it to be able to be resistant against antibiotics potentially and evade the immune system. Now, what kind of things would it love to form biofilms on? This is a very important thing. It loves to form biofilms on kind of like intravascular catheters. So you would see this forming a biofilm on like vascular catheters. So vascular devices of some kind. You would see this forming kind of a really nice biofilm on urinary catheters. And you know what else? It loves to form on particular types of prosthetic devices that are basically inserted into the body, especially prosthetic valves and joints, prosthetic joints. Okay, so it's really important to remember that these can form biofilms on prosthetic valves. They can form prosthetic biofilms on prosthetic joints. They can form biofilms on urinary catheters and biofilms on vascular devices. The main concept behind this is that whenever you're actually inserting in a catheter, you're going through the skin. Staphylococcus epidermidis is a part of our natural skin flora. If you're actually inserting a urinary catheter or a Foley catheter into the bladder, you have to pass through the skin near the actual urinary tract. Staphylococcus epidermidis is near that area. Again, prosthetic joints. If you're putting in an actual prosthesis, whether it be into the heart or into an actual area of a joint like a hip joint, you're having to open up the individual and allowing for you to, when you open up the actual skin or open up the area to access that particular area, you're allowing for potentially putting in a prosthetic device that could be covered by Staphylococcus epidermidis. Once it's actually inside, it can create the exopolysaccharide covering or biofilm, allowing for it to be able to produce certain types of diseases or infections, and then again be potentially resistant to antibiotics. Okay? All right, so we got Staphylococcus saprophyticus. Now this one also, again, very, very interesting, can produce its kind of like diseases or its really nastiness by the process of things called biofilms. And we already have a pretty good understanding of this. It produces that exopolysaccharide. But the other mechanism by which it can actually really kind of cause problematic issues is that urease enzyme. The Staphylococcus epidermidis also has the urease enzyme. But again, I want us to really, really hone in on it with Staphylococcus saprophyticus. So again, let's say that you're putting in a Foley catheter. A person has urinary retention. You're trying to monitor their, their intake and output, stuff like that, right? And so you put in this catheter. When you go through that area, you're going to be touching the skin of some kind near the urinary tract and probably pick up some of the Staphylococcus saprophyticus. And so therefore, it may kind of like be on the urinary catheter of some kind, okay? And it has the ability to produce the biofilms. We already know that, which can make it resistant to potentially antibiotics. We know it can kind of evade the immune system, the whole 9 yards. But here's what makes it even worse. Staphylococcus saprophyticus has this urease enzyme. You know the pH inside of the pH of our urine is usually low. You want it to be kind of acidic. It's harder for bacteria to thrive in acidic environments. The protons kind of alter they kind of lead to the denaturation of enzymes and DNA, so on and so forth. So what this urease enzyme does is, you know, with inside of the urine, there's a particular molecule called urea. The urease enzyme, which is from the Staphylococcus saprophyticus, it'll release the urease enzyme. And the urease will then do something very interesting. It'll break down urea into two components. It'll break it down into CO2, and it'll break it down into ammonia. Now, ammonia is a base, okay? So what this is gonna do is it's gonna bring the pH back up. If you increase the pH, you can increase bacterial growth, because now it's easier for bacteria to grow in higher pH environments. Pretty cool, right? And not for us, but for the bacteria it is. Another thing is that this ammonia will combine with some of the other solutes present within our urine. Magnesium is a very interesting solute that's present within our urine. Sulfate is a molecule that's present within our urine. And so what happens is the sulfate and the magnesium combine with the ammonia and lead to something called struvite. Okay, so struvite crystals. And this can produce little types of stones. And those stones can potentially obstruct parts of the urinary tract. Now remember, the Foley catheter is one way by which we can introduce the bacteria into the actual bladder. That's not the only way. Remember what I told you, if you're a back to front wiper for females, you take the potential of wiping that bacteria from the area of the perineum near the urinary tract, and then the bacteria can travel up the actual urethra and into the bladder. So there's a couple ways that we can get it in there. Once it's in there, it has this ability to produce biofilms or change the pH. And you know what else it can do? It can produce these struvite crystals, which can kind of lead to like a obstruction of some kind, like a urinary outflow tract obstruction. Maybe it produces like a little stone somewhere within the bladder or within the urinary tract somewhere. And that can also cause problematic issues as well. Okay? So that is all the kind of pathogenic mechanisms of the Staphylococci bacteria. Now let's talk about the diseases that we actually see as a result of these pathogenic mechanisms. All right, so let's talk about how Staphylococcus aureus, through the kind of pathogenic mechanisms, leads to particular types of diseases. One of the big big ones is skin infections. We see a lot of skin, soft tissue infections with Staphylococcus aureus, right? Now, not everybody's just walking around with staph infections every single day. It's a part of our skin flora, right? But if you have big breaks within the skin and you have heavy amounts of Staphylococcus aureus on the skin and they invade in through that break within the skin, it can then lead to tissue damage, causing lots of white blood cell inflammation, lots of white blood cells coming to the area, leading to inflammation, leading to redness, leading to pain, and this can lead to a lot of different skin and soft tissue infections. For example, if there's like an infection or inflammation around like a hair follicle, this can lead to something called a furuncle. And a bunch of furuncles can come together and lead to a carbuncle. So just big old boils. The next thing is, if it just infects like the actual aspect of the epidermis. You know, sometimes there's Staphylococcus aureus that can infect just the epidermis. And this can lead to something like an impetigo. If it starts to infiltrate into like not only the epidermis, but starts involving like the dermis, this can lead to a cellulitis. And not only that, but if the infection starts actually spreading into the dermis and starts causing lots of bacteria to come into the area, and your immune system, your bacteria, immune system, white blood cells, all of that stuff, broken down cellular debris, you try to wall off that infection, your immune system tries to do that, and you just do like a big old sack of pus within inside of the actual dermis, this can lead to something like an abscess. Okay, so big things to remember: skin, soft tissue infections. Again, infection of like the hair follicles, particularly like furuncles, and then potentially becoming a carbuncle. Infections just of the epidermis, like an impetigo. Infections of the dermis, like the cellulitis. And then if you lead to a walled-off infection containing cellular debris, bacteria, white blood cells, this can lead to an abscess. Now, here's what's even more interesting: these bacteria, if you get something like a cellulitis or an abscess, these bacteria can contiguously spread through the dermis, through the subcutaneous tissue into the underlying structures. What's below the fat tissue within our arm? You start getting into like particularly connective tissue, muscle tissue, bones, joints. If this actual, let's say here's the infection right here, right? If these bacteria spread and they spread to the muscle, they can lead to inflammation and infection of the actual muscle, leading to what's called like a pyomyositis. If they infiltrate into the actual bone tissue and lead to infections of the bone tissue and damage and destruction of the bone tissue, this can lead to something called osteomyelitis. If they start infecting the actual joints and leading to inflammation and infections of the actual joints, this can lead to a septic arthritis. So from an actual infection like cellulitis, an abscess of a skin, soft tissue, if they're able to infiltrate deep from that area contiguously, it can then lead to pyomyositis, osteomyelitis, or even a septic arthritis. So that's something else to think about. Now, not only could they contiguously spread through the skin and soft tissues into like the area of the bone and joints, but you know what else you have nearby? You have little blood vessels, right? So you have blood vessels here. What if the bacteria spreads into the blood? And then from the blood, you have something called bacteremia. Bacteremia is just basically when you have that bacteria within the blood. So there's a bunch of bacteria within the blood, bacteremia. Well, look what happens here. Bacteremia can be somewhat a normal process and not lead to a bunch of issues. But if the actual bacteria within the bloodstream start causing disease and start causing significant infections, you start looking at more of kind of a septicemia kind of effect here. If the bacteria gets into the bloodstream, okay, and it starts doing something else, it starts invading into tissues via this hematogenous route. So it's spreading contiguously, so through the skin, through the soft tissue, causing these infections. But if it's able to invade into the bloodstream and then go and infect other organs through the blood, that's the hematogenous spread, okay? Let's say that it spreads and infects the meninges, leading to something like meningitis. So you can develop a meningitis due to Staphylococcus aureus. Maybe it leads to an abscess. So not only you get inflammation and infection of the meninges, maybe you get like an abscess in the brain. So it can lead to a brain abscess. That is another thing to think about as well. What if the bacteria spread through the blood and they get into the lungs? and they start causing an inflammation and infection of the lungs. This can lead to pneumonia. You know what is really important to remember about this for the exams? You usually see this in elderly people after they've been infected with the flu. That is a super important thing to remember. So if someone starts developing a bacterial lung infection and they're elderly and they ask you like what is a particular thing that is a risk factor to them having this, it's them having a previous influenza infection. So don't forget that for your exams. The other thing is, what if these bacteria not only spread to the lungs, but they also spread to the heart? And you know where they love to attack? They love to attack the valves. They love to attack the heart valves. And when they attack the heart valves, they start leading to a lot of infectious vegetations on the heart valves. And this can lead to what's called an infective endocarditis. It can lead to an infective endocarditis. So one of the big things that I want you guys to remember is that Staphylococcus aureus can cause skin and soft tissue infections, can spread contiguously through the skin soft tissue to areas nearby like the muscles, the joints, and the bones, leading to these infections. They can spread through that actual skin soft tissue infection into the blood, leading to these things like meningitis, brain abscess, pneumonia, and infective endocarditis. You know what else? What if you're an IV drug abuser? What if you just had surgery? What if there was some other reason by which it wasn't actually spread through an infection of the skin, it was introduced through some kind of like foreign like needle, okay? For example, if someone is a IV drug abuser, that is a big, big risk factor for spreading Staphylococcus aureus. And another thing is some kind of surgical procedure. So another thing is any kind of surgery, maybe dental work. Maybe you're actually opening up different areas and allowing for that Staphylococcus aureus to get spread. But please don't forget IV drug use is a big, big way by which Staphylococcus aureus can get spread. Okay? All right, that's the ways that I want you guys to remember the big kind of infections. To go back and quickly review how some of the exotoxins can produce very specific types of diseases. Do you guys remember what it was called whenever you had a rash, hypotension, and fever due to having a tampon just sitting in that area for too long? Toxic shock syndrome, right? Due to toxic shock syndrome toxin type 1 inducing these effects, leading to toxic shock syndrome. Boom. The last thing is, do you guys remember what was the name of the actual toxin that caused destruction of the desmoglein? It was the exfoliative toxin. And that exfoliative toxin was actually leading to destruction of the desmoglein, leading to separation between the keratinocytes, causing a lot of inflammation, and then leading to kind of a red rash that then progresses to blisters. And these blisters, actually, if you just take and rub over it, it'll cause the blister to like open up and the skin to slough. What is that called? There's a very specific name for that. It's called a positive Nikolsky's sign. So that's a big thing to remember. And this is something that you see with a very specific disease called staphylococcal scalded skin syndrome. Staphylococcal scalded skin syndrome, also known as Ritter's disease. The last type of effect that we can also see from Staphylococcus aureus, not directly but via its exotoxin, is the enterotoxin effect, right? So we talked about this also briefly. The enterotoxin can also lead to destruction of the epithelial lining of the GI tract, and it's going to alter the absorption. It's going to alter the ability for movement of electrolyte. It's going to lead to electrolyte shifts, and it's going to basically lead to diarrhea. And from this, we can see things like gastroenteritis, usually secondary to some type of food poisoning. So usually secondary to food poisoning. And remember what I told you to remember, it's usually some type of like mayonnaise-based type of food substance, okay? So that is all the diseases and syndromes that we can see associated with Staphylococcus aureus. Let's briefly cover Epidermidis and Saprophyticus. All right, so Staphylococcus epidermidis. We talked about how it's a part of our natural skin flora, and it loves to kind of basically hang on to particular types of foreign devices. One is, we said, vascular devices, right? And we said that it can lead to catheter associated, so we can maybe get some type of catheter associated infections. For example, like if someone has like a central venous catheter and like a subclavian vein or an internal jugular vein or femoral vein, it may lead biofilms on that type of catheter, therefore leading to infections. Here's a really high yield topic that you have to remember. It's also a very important clinical topic to remember, is that Staphylococcus epidermidis, sometimes when you do what's called blood cultures, you're taking basically blood and culturing it for bacteria. And this is one of the most common part of our skin flora. So it is a very common contaminant for blood cultures. Why is that important? If you go ahead and order some blood cultures on a patient and it comes back and it's like, oh, Staphylococcus epidermidis positive, you can be like, oh, that's okay, it's a contaminant of the actual blood culture from the skin. Okay, so that's a big thing. And usually, you know how you treat these? Pull the actual device, because again, antibiotics aren't going to be super great. It's really just removing the device, and that's going to help with the actual infection. Again, because it likes to form biofilms on catheters, you can also get something called a catheter associated urinary tract infections. So what's called a CAUTI, catheter associated urinary tract infections, because when you put in a Foley, and this is a part of that skin flora, it gets picked up, leads to a biofilm, leads to infection. How do you do it? How do you treat it? Don't really worry too much about antibiotics. You can give antibiotics, but the big thing is get rid of the catheter. Again, you're going in, you're getting a prosthetic heart valve. When you do the prosthetic heart valve, some of the actual bacteria loves to form on that valve. It can lead to a prosthetic valve. So it can lead to what's called like a prosthetic infection, a prosthetic valve infection, almost like an endocarditis basically. Okay, so pretty much like an endocarditis of the actual prosthetic valves. Also, if it's on like a prosthetic hip joint, okay, maybe you get like a prosthetic joint that gets put in, and it starts to actually form some infections around that actual prosthetic joint, you may get what's called a prosthetic joint infection as well. Okay. And usually it's something as simple as like having positive blood cultures and evidence of like an infection, a fever, an infection actually representative on like a esophageal, transthoracic echocardiogram. You see kind of evidence of vegetations. Or you have pain, you have fever, you have redness over a joint, and maybe even like pus, it kind of actually exsanguinating from the actual area around where the prosthetic joint is. These could be kind of identifiers of Staphylococcus epidermidis. Okay, so again, remember these as particular infections. Catheter-associated infections, big thing here is a contaminant of blood cultures, CAUTIs, prosthetic valve infections, and prosthetic joint infections. Next one is Staphylococcus saprophyticus. All right, and then the last type of bacteria here again is Staphylococcus saprophyticus. Remember, if it has the ability to travel from the perineum or through a Foley catheter, any way that it can get introduced into the bladder and start causing infection of the bladder and potentially even spread from the bladder up through the ureter and then into the kidney, it can lead to urinary tract infection. So either way, you can get something called urinary tract infections, UTIs. And this could be either due to kind of inflammation and infection of the bladder, like cystitis, or it could be inflammation and infection of the actual kidneys and part of the actual ureters, leading to something called a pyelonephritis. But either way, these are categories of urinary tract infections. So that covers the infections and diseases that we see from these species. The last, or these types of bacteria, the last thing that I want to cover is how do we treat it? All right, so now let's talk about the treatment of Staphylococcus aureus and Epidermidis saprophyticus. So it's very important for us to understand another underlying topic with this, which is how antibiotic resistance comes into play. So you know Staphylococcus aureus, originally, let's say that you had the ability to treat it with penicillin. These bacteria are so nasty that they've just come up with ways to be resistant against penicillin. And then they came up with another one called methicillin, and it became resistant to that. And then we start treating with something called vancomycin, and it's become resistant to that. How do we know this whole process? Let's go through the ways that it's become resistant, and then we'll talk about the antibiotics that are treating those particular categories of Staphylococcus aureus. All right, so the first one is, let's say that we have some Staphylococcus aureus here, and it has the ability to produce an enzyme called a beta-lactamase. So this beta-lactamase basically will inhibit any kind of beta-lactam, particularly any kind of beta-lactam antibiotics. there's only kind of a couple antibiotics really that still have some effect against this Staphylococcus aureus, even though they have this beta-lactamase presence. So again, if the Staphylococcus aureus releases this beta-lactamase, it can inhibit certain beta-lactam antibiotics from being effective. This puts this type of Staphylococcus aureus in the category of what's called, it's not resistant to another type of antibiotic called methicillin. It's sensitive to it. It just produces the beta-lactamase. So we call this methicillin sensitive Staphylococcus aureus, also known as MRSA. MRSA is very sensitive to certain types of antibiotics like oxacillin and nafcillin. So these are antibiotics that I can use to treat methicillin-sensitive Staphylococcus aureus, okay? And we should try to narrow our antibiotic spectrum if we can. You want to try to avoid using broad spectrum if possible. All right, so let's say that the Staphylococcus aureus says, okay, I don't want to be, sensitive to oxacillin and nafcillin anymore. I want to be a little bit more resistant. Okay, and so this is where they started to use like this antibiotic called methicillin, right? And they particularly in like studies and stuff like that to see if the bacteria would be sensitive to them. And so again, utilizing this methicillin, certain types of Staphylococcus bacteria, Staphylococcus aureus, would be sensitive against the methicillin, and they would, not able to still grow. Okay, and that's where oxacillin and nafcillin were effective. But then they started finding that the bacteria were becoming more resistant to the methicillin, and then therefore oxacillin and nafcillin were not good antibiotics for that anymore. How did it do that? Well, there's a gene that the Staphylococcus aureus species start actually kind of developing, and it's called a MEK-A gene. The MEK-A gene leads to the actual production, okay, the translation of a very specific type of protein called a penicillin binding protein type 2A. It's like, what the heck? This protein is different in a way that now certain types of antibiotics like methicillin or oxacillin and nafcillin and other things like that are no longer effective. And so it decreases the efficacy of methicillin and other kind of like similar antibiotics. Okay, the reason why is it changes the structure of the penicillin binding protein. That's why it's penicillin binding protein 2A. It changes the structure of it in a particular way where methicillin, oxacillin, nafcillin, other types of beta-lactam antibiotics aren't able to interact with that protein. You know, penicillin binding protein is a transpeptidase. It basically helps to kind of grow our cell wall. If we inhibit the penicillin binding protein, we won't be able to grow the cell wall. We inhibit that transpeptidation process. The methicillin is no longer able to exert its effects, or oxacillin or nafcillin or other types of penicillin-related antibiotics. And so because of that, its efficacy is diminished, and now these bacteria are resistant to methicillin, oxacillin, nafcillin. But we like to put them into a category particularly specific with methicillin. So we call these bacteria methicillin-resistant Staphylococcus aureus, or MRSA. So I can't use oxacillin, I can't use nafcillin, I can't use amoxicillin, I can't use any kind of penicillin or really a good beta-lactam antibiotic. So I need to kind of start branching out. And that's where we start getting things like vancomycin, which is one of those big drugs that we hear about all the time utilized in hospitals, like an IV form. This is really good for what's called your hospital-acquired MRSA, because you have two different types. You have your hospital-acquired MRSA, and then you have your community-acquired MRSA. The vancomycin is really kind of the best way to treat the hospital-acquired MRSA. Your community-acquired MRSA infections, those can be better treated with other types of antibiotics. You can use things like doxycycline. You can use things like clindamycin. And you can even use what's called a trimethoprim sulfamethoxazole, TMP-SMX, also known as Bactrim is the brand name. These are particular types of antibiotics that would treat more of the community-acquired MRSA, and then vancomycin would be better for your hospital-acquired MRSA, okay? So again, that's a big thing to remember here, okay? So we have MRSA, we have MRSA. The bacteria are getting even stronger, man. Vancomycin is a really powerful antibiotic, especially against certain types of MRSA species. Okay, but what if this Staphylococcus aureus became even more resistant? And it does. it says I'm going to make another gene called a VAN-A gene. And this VAN-A gene is going to alter the peptidoglycan cell wall. And I'm going to alter it in such a way where vancomycin efficacy is going to drop significantly. And so vancomycin won't be able to inhibit the cell wall process, the cell wall synthesis process anymore. And I'll be able to survive even despite the presence of vancomycin. Now we have something called vancomycin-resistant Staphylococcus aureus. So now I can't use vancomycin anymore. I got to find other antibiotics to be able to treat this type of bacteria. And there's a bunch of these. The big one to remember that you're probably going to want to remember for like exams is something called linezolid. Okay, so don't forget that. That covers the treatment of the actual Staphylococcus aureus with truly trying to understand why certain antibiotics are best for certain types of staph species. Okay, particularly aureus. Now let's talk about Staphylococcus epidermidis. All right, so Staphylococcus epidermidis. This is pretty much going to have somewhat of the similar activity again that we talked about as Staph aureus. So the Staphylococcus epidermidis, it also can make an enzyme called the beta-lactamase. So therefore it can inhibit the beta-lactam antibiotics. And therefore it can be resistant to certain types of beta-lactam antibiotics. Okay? But it's still sensitive to things like similar to oxacillin and nafcillin like methicillin. So this is technically within the category of a methicillin-sensitive Staphylococcus epidermidis. So it's technically what's called a methicillin-sensitive Staphylococcus epidermidis. And so you can treat these types of infections with oxacillin and nafcillin. But if you have this actual bacteria here, develop a way of becoming somewhat resistant to the actual methicillin. It develops a resistance to that. For example, it starts having these genes called the MEK-A gene. And that MEK-A gene starts actually leading to an increased production of PBP2A. So it changes in the penicillin binding protein. And that decreases the efficacy, we'll just put efficacy of methicillin. Then we can't use things like oxacillin and nafcillin. We have to kind of change it up a little bit. And so we start having something called methicillin-resistant Staphylococcus epidermidis, and this is where we would have to use something like vancomycin. But remember what I told you is really kind of one of the easiest ways to treat this infection? Sometimes it's as simple as because it's an infection of a catheter, like a Foley catheter, or an infected venous catheter. In certain situations, like an infected, like a prosthetic joint or endocarditis, we could use things like oxacillin and nafcillin or vancomycin. That would be kind of worthy of treating, like a prosthetic joint infection or a prosthetic valve infection. We could use something like oxacillin, nafcillin, or vancomycin. But if it's something like a caudy, or if it's like a catheter-associated urinary tract infection or a vascular infection from a catheter, what do? Get rid of the device, pull the device. So if you remove the device, you technically can remove the infection, because what's the way by which these types of bacteria really cause infections? Biofilms. So even trying to give them antibiotics sometimes aren't going to be super effective. They're going to be able to evade the immune system. So get rid of the catheter or the foreign device and you remove the infection. Okay? Staphylococcus saprophyticus. This guy right here, he's a very interesting one. Okay? When he produces infections, he produces urinary tract infections. And really, there is a very specific subset of antibiotics that you give to patients with urinary tract infections. Again, the most common types of infections that you see with this is cystitis. It sometimes can cause staphylococcus, it can sometimes cause pyelonephritis, but you're going to see cystitis is going to be the most common aspect of the urinary tract infections with this bacteria. And the first line antibiotics that you treat with cystitis, it's just the ones that you primarily give, is going to be something called nitrofurantoin, also known as macrobid. Another one is called trimethoprim sulfamethoxazole, known as Bactrim. And then the other one is something called phosphomycin. So phosphomycin, which is kind of like a one-time dose. So these are particular types of antibiotics that you treat Staphylococcus saprophyticus with, usually if it's due to an infection like a urinary tract infection, usually cystitis. Now, if you can't give these for whatever reason, if there's a contraindication to giving them, it's not effective against it, for whatever reason, you have other options that you can reach for. Other options that you can treat with include something like cephalexin is a particular type of antibiotic that you can give. Augmentin is another one as well. These are usually your second line. You usually don't have to use these too often. One is because cephalexin, you have to almost take it 4 times a day. So there's a decrease in compliance there. But again, these are potential alternatives if there is a contraindication to these. The only other one that you can mention here is that there is potential for ciprofloxacin. But generally, we really try to reserve this one. We try to avoid having to give ciprofloxacin because there's a lot of adverse effects with this drug. QT prolongation, you have a lot of interaction with particular drugs with the cytochrome P450 system, and on top of that, the potential of like Achilles tendon rupture. So, and there's also lots of resistance for this drug in certain populations. So ciprofloxacin is really only reserved for very resistant cases of urinary tract infections, and that's when you would particularly give this. So again, big thing to remember here, Staphylococcus saprophyticus, these are the first line antibiotics. These are your 2 second line, and this is for more of your resistant cases or chronic cases of UTIs. All right, Ninja Nerds, in this video we talk about the Staphylococcus bacteria. I hope it made sense. I hope that you guys enjoyed it. All right, Ninja Nerds, as always, until next time.